All right. Welcome to the Hawaii Variable, a database discussion about COVID-19 in Hawaii, hosted by Honolulu Civil Beat. I'm Alani Eagle. I'm the Membership and Events Manager for Civil Beat. This event is being recorded and we are streaming live on Facebook. You will be sent a recording of the webinar and slides in our follow-up email if you signed in through Eventbrite. For those of you joining us on Facebook, I'm sorry, but we will not be getting to your questions, but you can email us at membership@civilbeat.org if you have a question right now. Honolulu Civil Beat is your local nonprofit news organization providing you with daily in-depth investigative stories. If you don't already subscribe to our Morning Beat newsletter, starting tomorrow, you will be receiving our daily newsletter in your inbox. It's easy to unsubscribe, so don't worry. And we also have a Civil Beat app if you prefer to get your news that way. So as a reminder, this event is meant to be a primer. We will explain the types of data epidemiologists use to inform the local policy in response to the COVID-19 pandemic. The discussion will also be guided by viewer questions, which were previously submitted. So any of the questions that we are unable to answer during the event will be passed along to our reporter, Yoohyun, and the panelists, and be used for future data-focused events or help our reporting. Our panelists today are Yoohyun Jung, Nick Redding, and Thomas Lee. So a little bit about our panelists. Yoohyun joined Civil Beat as the criminal justice reporter in the midst of the Kealoha trial. She's recently changed beats and has assumed the role of data reporter, launching a new column, The Hawaii Variable. Before joining Civil Beat, she worked across media platforms in the United States and South Korea. Nick Redding is the executive director of the Hawaii Data Collaborative. He is a member of the Hawaii Pandemic Applied Modeling Work Group, a voluntary brain trust to help confront the challenges of COVID-19 via the use of data and models. Thomas Lee is an Thomas Lee with the University of Hawaii at Manoa is born and raised in Manoa, attended Punahou School, and got his undergrad in Chinese from the University of Notre Dame. He completed his master's and doctor in epidemiology from UH Manoa and also a second BA in public health. Currently, he is an assistant professor of epidemiology and a medical officer in the 1984 U.S. Army Hospital Pacific, 9th Mission Support Command, activated for over the past 2 months to assist the state in the Hawaii Emergency Management Agency as their lead COVID modeler and forecaster. Thank you for joining us today, everybody. I'm going to hand the mic over to Yoohyun.
Hello, everyone. Welcome to the webinar. My name is Yoohyun Jung. Thank you, Alana, for the introduction. I want to tell you a little bit about the Hawaii Variable. It's just launched, and I hope you guys had a chance to read some of the articles that I've been writing. So it's a weekly data column. And Alana, could you show us the slide introducing the column? And it's basically published every Sunday, and I write about data about Hawaii and try to give you more of a context of what that data is about and how it's relevant to all of us. And also, I'm really seeking to interact with the audience while I do that. So I want to answer people's questions, and I'm not necessarily the expert answering your questions. I seek out the help of people who know much, much better than me to do that. So actually, we have a Google form for the Hawaii Variable that I circulate that people have been submitting questions to, that you can use the form to ask questions. And I'll circulate that link in our chat as well. So if you have any questions about data in Hawaii, things you think I should request and start looking into, things you think I should build a database for, please let me know. Thanks so much. And I will pass the mic on over to Nick.
Great, thank you so much. Hi, everybody. Great to be with you virtually. As Alana said, I'm Nick Redding with the Hawaii Data Collaborative. We're a nonprofit organization that engages partnerships to elevate good data and analysis for the important issues that we're faced with here in Hawaii. I don't think there's going to be any argument among the audience that COVID is an important issue that we're faced with. And when COVID hit, we immediately started to respond to the crisis in a few different ways. Some of you might be familiar with our COVID-19 dashboard that we put up that pulls together data from multiple sources that kind of helps us as a community of leaders and concerned citizens and policymakers, et cetera, to kind of understand the day-to-day picture of the continually rapidly evolving situation of COVID. We've also been working and continuing to work to partner and provide capacity support where needed. Sometimes it's firefighting where we're just trying to get in and provide a data or analysis lift where needed to help move something forward, helping maybe it's a county agency with a dashboard, maybe it's a nonprofit with some analysis or data that speaks to some of the programmatic considerations they're faced with. And then from the beginning, we recognized that systemically here in Hawaii, there was a challenge around understanding the unique considerations we're faced with and what the health science tells us about what might lie ahead. Very early on, you might remember we were very concerned with flattening the curve. So understanding like if we actually do stay at home, if we do close our businesses, et cetera, what does that actually mean for the spread and the consequences for our hospitals, et cetera. So we did some work in that area, put up a model of that. And then the next question you might recall was, when are our hospitals going to reach peak? And so we did a scan to see what was out there that could help us understand when we might expect peak hospital capacity. Thankfully, we never got anywhere close to that. But what that made us aware of systemically was the need to mobilize local health scientists, epidemiologists, and other experts to really help us understand what's happening locally. A lot of the models we were drawing from were mainland models that while they applied local data, they did not apply local context. And so we began to do a scan to see where were the opportunities that the Data Collaborative could support elevating the work of local experts for all of us to benefit. That's where I met Thomas, and I met an early group of concerned researchers that were coming together to discuss that very thing. So I think that's a good lead up for Thomas.
Thanks, Nick. So aloha, everybody. Thank you for coming to this great talk. Just for everybody's awareness, I am over the interweb, but I am 5 hours ahead of everybody in San Antonio, Texas, which is unfortunately still a pretty big hotspot for COVID. So just a little backstory about HIPAM and how HIPAM got started. When this was really starting to become very serious for Hawaii, I was just doing my normal professor duties, teaching global health and epidemiology, and just playing more of a casual observer to this. Through the Coconut Wireless, I got a call asking if I would be willing to participate and assist the Hawaii Emergency Management Agency as their lead COVID modeler, because as Nick pointed out, there was only one particular model trying to predict what was going to happen in Hawaii in the first 2 weeks in April. And we quickly realized some severe limitations to that. So trying to develop a Hawaii-specific model, and in that short time frame, realizing that one person alone was not enough, definitely not enough to cut it. So working with Dr. Victoria Fan and a bunch of other great academics at UH, along with community partners from Queens, HPH, and other entities, we quickly formed to address Hawaii-specific COVID problems, utilizing Hawaii-specific data as best as possible, and currently working on addressing some of the gaps and limitations in that data to improve upon our modeling. And I just wanted to, on a side note, on a very sad note, but Mary Guo unfortunately left us a few days ago, but she was an integral part of HIPAM, and I wanted to make sure that her work and contributions were duly noted here. So with that, I think we're ready for the next slide.
All right. So I'm going to go over the agenda for today's discussion a little bit before we get started with all of this. We thought that it might be a good idea for us to cover some basic ground before we get started with our discussion portion. We have some basic data terminology that we're going to cover so our discussion doesn't get totally lost on some folks. I know that we're going to start throwing, especially our expert panelists, they're going to start throwing some words around that can get totally lost into the void. So we're going to quickly go over some of this terminology, get them out the way so that everybody can follow along with the discussion, whether they're healthcare professionals or just news readers, as most of us are. Frankly, when I started talking with these guys over here, I was like, well, you said what? I couldn't even understand some of the words. So we try to really get ahead of that by preparing these slides. So we're gonna get these out of the way, and then we're gonna have some discussions about what data is available versus not and why. And then we're gonna go over how some data actually affects policies. And then we'll take some of the questions that you guys have. And we've already been getting a lot of questions through the form, and people have been emailing us questions and whatnot. Some questions were similar, and so we've kind of taken into consideration the similar questions and helped those questions guide our programming today. So I hope you guys take that into consideration. And if you think your question wasn't selected or something like that, we had a lot of them, so we tried to make sure that everybody's questions could somehow at least indirectly be answered by combining them into these different exercises. Okay, so first of all, I'm going to take charge in explaining some very basic data terminology. Alana, next slide, please. We'll go to the next one. I'm pretty sure you've all heard this before, aggregation versus disaggregation. So aggregate data basically means that they've already been summarized in some way. They've been lumped up in some way. So they've already been analyzed. So by extension, disaggregation means broken down. So disaggregated data is broken down. For example, like broken down by age or race, that's disaggregated data. Next slide, please. Moving average. You're going to hear this a lot in COVID data. You'll probably also hear this a lot in financial data like stocks. So it's actually calculation of a series of averages of different subsets of a full data set instead of just, 1 + 2 + 3 divided by 3, because that's 3 values. So this is an important term to know because it helps draw us trends and helps observe random variability or fluctuation. So you can see why this is an important term to know in epidemiology. Next slide, please. Per capita. You hear this a lot in, census survey. You guys, I hope everybody's filled out their census. You can do it online now. It's really easy to do. Very basic form of civic engagement. Get counted, get your money's worth. Per capita just means per person. They had to confuse us by calling it something different, but it actually just means per person. It does not mean per 100,000. Per 100,000 is per 100,000. So just remember that. And next slide, please. And this is confusing also for no reason, but this is also an important distinction, I think, in terms of reading into the COVID data. So rate versus count. I lifted this from the City of Houston's health department for your easy understanding. So when it comes to health data, rate means the number of events that occur in a defined period of time divided by the average population at risk of that event. Count is just 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. All right, next slide, please. well, that's it for me. That was easy, right? Well, the other stuff that these guys are going to get to, not so easy. So I'll pass that hard part on to, I think, Nick, you're next.
Great, thank you. Alana, could we have the next slide, please? So while this is coming up, hopefully many of you watching were able to read Yoohyun's great article that came out, I think, Sunday in Civil Beat about the Resolve to Save Lives framework, which basically laid out, I think what the way they described it was, 15 COVID indicators that should be in every state dashboard. And in reading through that, I think it's a great contribution. And also what struck me was how important it was to kind of understand and contextualize what each of those indicators that they suggest each state make available does for helping us understand our local COVID-19 situation. And so one frame for thinking about that is what each indicator is in terms of whether it's a leading or a lagging indicator. Leading indicators are forward-looking. They help us understand what lies ahead, whereas lagging indicators give us a sense of what's happened. So to apply that to COVID, let's look at, there's a lot going on the slide, but if we just start with right in the middle, 7-day average of new cases, I think all of us are used to seeing in news accounts, or maybe we check it ourselves every day on Department of Health site or somewhere else. We look for, how many new cases have been reported today. That's the current situation. It's what we're interested in because obviously it's consequential to how many more cases and what the average of new cases and how that's changing every day is really important. But if we think about the landscape of data points that help us understand that thing we're most interested in, if we first look at, well, what is suggestive of what's going to move the number of new cases, whether it increases or decreases, a lot of that has to do with the likelihood of transmission. So we can think about things like PPE utilization, social distancing behaviors, facilities, whether it's retail, restaurants, or other facilities that people frequent or will end up interacting with each other. The extent to which those things are going well, the extent to which we're using, most of us are using PPEs, most of us are maintaining our distance from each other, we're able to safely make use of facilities that have guidelines in place or following the guidelines to keep us from interacting too closely. The better that we do that, the more that goes up, the less likely we are to see more or increases in new cases in the coming weeks. On the other side of this is lagging indicators. So rather than, when we first have new cases, what that may translate into is for some, they'll get sick, they'll need to go to the hospital and seek help. And unfortunately, sometimes it results in a fatality. We call those lagging indicators. They represent, they're backward looking. They tell us what the outcomes were of what happened in the preceding days and weeks. So leading tells us is forward looking. It gives us a sense of what's going to happen. Lagging gives us a sense of what has happened. Still on top of the leading to lagging bar there, what I'd also point out is that we've highlighted in blue those data points that are publicly available to us here in Hawaii. So we can see that we do see the new cases every day, and we also get daily updates on new hospitalizations and fatalities. And in fairness, for us to actually have a regular accounting of the leading indicators that we're describing here, like PPE utilization, is challenging. It's hard to measure that day in and day out there publicly. So there are ideas about how to do that, but it's not as readily available as some of the other indicators. Below the line are other indicators that are also very important, and they do have a leading and lagging role, but it was harder to define exactly where they might fall. So one that we see is contact tracing and COVID testing capacities as a leading indicator. The extent to which we're able to quickly trace contacts of those who have been positively diagnosed with COVID, have had a positive test, is very important. And if we are not able to respond quickly in that way, that both serves as a leading indicator of what might likely lie ahead in terms of new cases, because we won't be able to identify and isolate cases as quickly, but also it gives us, it makes us a little less confident in the 7-day new cases, the 7-day average of new cases that we're seeing, because it could be that we're not getting the fuller picture. And the same with testing capacity, that if there are delays and lags in from test to receiving result, that can also be problematic in terms of someone knowing that they have an infection, or again, us having the best count of new cases. On the other side of that are the clusters and super spreader events. Those are the kinds of things that are lagging, in the sense that that's something we should have avoided happening. It did happen, and it gives the 7-day average cases a kind of bump. And we usually kind of see that after the fact, that we're able to explain increases in cases by certain events and things like that. So it's a little more on the lagging side. Lastly, what we have on here that is something not unique to Hawaii, but pretty unique to our situation, which is being able to be aware and monitor travel volumes and how travel might relate to transmission. And so we do have a daily update from the Hawaii Tourism Authority of the number of travelers that are coming, the number of arrivals every day. And then we also, from the Department of Health, are made aware, with a little bit of a lag because it takes time for the contact tracing to do its thing. We learn whether or not new cases are the result of community transmission or travel-related transmission. So just to zoom out really quickly, we have lots of data points either already available to us or could be available to us as we start to evolve and improve our accounting. And what's important is that we have that full landscape. We need to know both what the leading indicators that would help us understand what lies ahead and perhaps take action earlier to avoid further new cases. But then we also need to see, kind of what are the outcomes of our current situation? How are our hospitals doing in terms of their ability to respond as people get sick and need support in that way? So with that, I'll hand it off, I think, to Thomas.
Next slide, please. Thanks, Nick. So before we get into the meat and potatoes, the really interesting stuff, as an epidemiologist, there are many important terms when it comes to understanding COVID, and I could spend over an hour, just talking about them. But to keep it short, here are at least 4 main terms. Hopefully, everybody has seen them. The purpose of this is just to refresh the memory and maybe highlight some of the differences that you may or may not be aware that exist between these terms, but are actually very important in noting the differences. So the R0, you've seen it either R0 or R0, really is how infectious the disease is in a steady state. So what that means is if you're in a bubble and there are 3 or 4 other people, and right now, to the best of our knowledge, we suspect that the R0 is around 2 to 3. What that means is if I'm infected in this bubble, I'm going to infect 2 to 3 other people without anything else impacting that spread of COVID. Now, how that differs from the RT, or the effective reproductive rate, is that the RT focuses on a single point in time metric. So the RT can fluctuate every single day, especially in Hawaii and other parts of the country where there are so many other things that impact it. So for Hawaii, a few things that impact the RT definitely is the amount of travel volume, how many people come in per day, whether or not a large proportion of our population wears masks, does the simple things like physical distance, stay home when sick. Those are things that reduce the effective reproductive rate. Things that can increase it or increase the possible rate of transmission would include increases in large gatherings, which we know will increase the probability of a super spreader or cluster event, which definitely increases the effective reproductive rate. So that's the subtle but very important difference between the R0 and the RT, or the effective reproductive rate. Now, the last 2 terms, case fatality rate and the infection mortality rate, may seem very similar, and they are, but there is a very big difference in that the case fatality rate deals with confirmed cases. versus infections are all COVID infections that may or may not have been caught due to testing. And we know, not just in Hawaii, but nationwide and other countries as well, that testing and testing capacity is a big concern because of supply chain issues, logistics, and especially for Hawaii, we have to fly out a certain proportion of our tests, so that adds the lag and really impacts what we see for our case fatality rate, which deals with the number of deaths of confirmed cases over the total number of confirmed cases, versus the infection mortality rate, which deals with a hypothetical greater number of infections, because we know we're not capturing all of the true infections of COVID because of our limited testing. So once again, this is an introduction to just a very important difference between the term case and infection. Case refers to, once again, confirmed case, versus infections may not be confirmed. So the number of infections is probably underreported because we're not capturing all of them. And with that, I'll move on to the next slide, please. So the next two slides, I really wanted to give the audience a peek into some of the thought processes myself and my team goes through in terms of creating a scenario. Before I go into that, there's this very important thing. If you take nothing away from what I say today, focus on the fact that there is no such thing as a perfect model. Modeling is not meant to predict the future. In fact, you know, thankfully, even though I'm in San Antonio, a lot of my family, my wife is in Hawaii, and I was tracking very closely the hurricane that really missed most of the island chain this past weekend. And if you look, right, the predictions of the models really shift every single hour, every single day. And if we were to, if NOAA were to predict the hurricane 2 weeks ago, they would not have been able to predict that. So once again, from a COVID modeling perspective, our goal is not to predict the exact number of cases in a week or 2 weeks. Where we really see our value, once again, is to provide left and right limits scenarios to provide to the decision makers, those who actually make the decisions, to have as best of a pure epidemiologic and scientific information as possible. So now walking through a theoretical scenario for reopening. In fact, I had to do this for a hypothetical August 1st reopening, and I did this early in July before I had to leave to San Antonio for Army training. But basically, really working with major assumptions, really from the policymakers on what they were saying publicly, and what we were getting internally from HAIMA, what they thought was going to be the best course of action in terms of opening. And then what I did was I took those assumptions and applied the epidemiology impact to that. So some of the major assumptions would be, well, assuming everybody gets tested up to 72 hours prior to flight, right? And then from an epi perspective, assuming that all the travelers, whether they're tourists or returning residents, when they fly back to Hawaii or fly to Hawaii, if we could go back to the other slide, please, they're not currently infectious. They are infected, so they've been exposed, but they're incubating, which means that they are not yet spreading the disease to others. Once again, that's an assumption. I know that in real life that's not true, but once again, there are just some things that mathematically would be too hard to get at. So there are always going to be assumptions to modeling. And then we account for that when we explain that to the policymakers, saying, you know, here's an assumption. We know that it's probably going to result in a possible underestimate of our projections. And then the last two bullet points, everyone's going to get temperature screened or get a health survey. Once again, that is based on what was said by our policymakers publicly at press conferences. And then we assume currently, until otherwise told, that our DOH, Disease Outbreak Control Division, has robust contact tracing capabilities, which we know is one of our best chances at preventing large community-wide spread, moving from a containment method to a more mitigation method. Next slide, please. So what you're seeing is the end result, and there's a lot of hard work that goes in between what you just saw to what you're seeing on the screen. And once again, remembering what this panel is meant to do is just meant to be an introduction. Hopefully we'll have a chance to walk through more of the nuts and bolts and nitty-gritty, which I know some of you are very interested in. But basically, this is the result that we present to the policymakers, remembering that not a lot of them have epidemiologic experience, but we wanted them to see visually and also understand the context with which we created these scenarios. So if you look at that purple slide, first of all, I apologize. Let me start with the title, Daily ICU Cases. What this graph represents is on any given day, how many people are currently going to be in the ICU statewide. Once again, we know it varies by hospital, by zip code, by island, but once, with what I was tasked to do, this was meant to be for the state. So what you see with the purple is the graph or the curve or the speed with which the curve increases if we were not to implement any type of screening 72 hours prior or have any temperature screening. So basically our reasonable worst case scenario, and some of the other things this takes into account is the increasing travel volume hypothetically we would see in August and September with our university students returning and theoretically an uptick in travel. And then that red line represents what we expect to see or our best guess at what we might think would happen if we implemented the 72-hour testing protocol, but once again, understanding that there are limitations to the implementation of that, and therefore we would expect that there would be people slipping through the cracks in terms of some false negatives for the PCR test, and also assuming that with the temperature and questionnaire screening that everybody gets at the airport, unfortunately, not everybody is going to be truthful. So we had to take that into account, that it might not, that temperature screening and questionnaire screening wouldn't work to 100% capacity. And the blue, once again, is showing a reasonable best case scenario if everything were to work as perfectly as possible with what we know how well the PCR test could work, and if everybody answered truthfully on the questionnaires, got screened, and if they were positive on the temperature screening, they accepted the PCR test. And once again, what you see between the blue and the purple is a range for a particular scenario, and how I explain this to the policymakers is given the information that you tasked us with the proposed policies, here is our best estimate. Once again, staying as true to the epidemiology and the math and the biology and the virology of COVID, here is our estimates, once again, turning it back over to the policymakers to consider not just the epidemiology and the science, but also the social behavioral and economic and all other impacts that the policymakers who were elected to make the decisions can make. Once again, we're just one part of providing the data for our policymakers. So hopefully this was a overview for everybody to kind of get a sense of how scenarioing and how we kind of walk through the scenario and then utilize this and provide this to our policymakers to make to assist them in making their best educated decisions for our state.
All right, thank you so much, Thomas. So that was one scenario for which we could have discussions about how policymakers could have a discussion on reopening as we call it, the economy or the state. So now we are going to move to a proportion where our panelists try to answer some of the questions. But before we get to answering questions that come directly from the chat, we had some questions that came in through the forums and through emails. And as I said before, we curated some of them and summarized some of them, consolidated some of them. So from those questions, a lot of what we got through the forum were basically asking, why isn't such and such data available? And or why is a breakdown for this data not available? Why is that not available versus how come this is sometimes available versus not that? So there were a lot of those individual questions coming in. So we thought it might be a good idea to try to do an inventory of what's actually out there. So Thomas and Nick, if we could try to put our heads together to give our audience an idea of what is actually publicly available for us to understand with data COVID-19 in Hawaii. Who wants to go first?
Nick, I'll give you the honors.
Well, maybe I'll do the kind of high level why, which is, just kind of trying to understand the procedures and processes and the systems that are in place to deliver data to the public. And I think it's important to remember that COVID is a new thing to us, a new thing to society. And I'm not privy to the conversations that happen internally, to DOH, for example, but one thing to consider is that their primary orientation is making sure they're doing their function well, which is the contact tracing and testing and all those things to make sure the state's response to COVID is appropriate and effective. And so I can imagine that it isn't the case that the primary considerations around what data should we be making available to the public get as much attention as some of these other things around how to mobilize to be effective in holding back the spread of the disease. What I'd also say is that, because it's new to all of us, we're still evolving. All of us are evolving our understanding of what we need to know and when we need to know it to be able to respond effectively. And so, like the Resolve to Save Lives report, what it pointed out, Hawaii didn't do so hot. They did the scale was 100%, in terms of if a state actually was at the reporting all the indicators that the report suggested, that would be 100%. Hawaii scored, I think, a 13, but the best state only scored a 43%. I think that was Minnesota or something like that. So, we're all kind of figuring out and learning, what we need to be sharing and have available to understand the spread of the virus, and it's things like that allow us to improve. So it's the feedback from decision makers, from business leaders and the nonprofits, feedback from concerned citizens, such as a lot of the viewers today, really help would help the DOH understand, like, what are people really interested in and wanting to know more about. So I just kind of wanted to put that high level setting out there as something we're constantly mindful of, is kind of being patient with our systems as we all build this shared understanding of what's the best information to understand COVID here in Hawaii.
Yeah, definitely want to echo everything Nick said, and to add to that, really, Department of Health has been doing a tremendous job, especially the disease outbreak control division. Really, they've been doing their best to get data out there. Once again, I think it's important for the public to remember that their primary job right now is to do contact tracing first and foremost, so that we can really contain the spread of COVID. Because once we lose our ability to contain it, unfortunately, then we may have to return back to the more mitigation type of efforts, such as closing down certain aspects of our economy, which I know we all want to avoid. So it's really important to remember that's DOH's primary focus when it comes to COVID. However, information is important. And if you look on social media, on the news, on a lot of academic sites, you're going to see lots of data points. While data is great, it is very important, especially for COVID, to recognize that not all the data are equal. And really, more data does not necessarily mean better information or better application to Hawaii. There's a lot of nuances when you look at data. I took a quick glance at the chat, and people are talking about overall number of cases versus percent positive, which are very important. Two things that are important to note. There are differences, but once again, when it comes to the data, is not one or two data points that are the most important for the state. Really, as an epidemiologist, it's looking at all of these things. What are the type of clusters? How many clusters? What is the age distribution? Where are the clusters located? In addition to factoring in future policies, but also what's going to happen in August. We know that DOE is going to open to some extent, and it's going to look different, and trying to get all those data points that we can to assist what we do in terms of modeling. So, I just want to show the public we are aware of all these multiple data points, but once again, not all data is created equal, and all the data in the world is not necessarily the best thing.
Absolutely, but I think it's prudent to point out that clusters are not a thing that DOH shares on a regular basis. They're selectively shared, like randomly. Some of these bars were named where there were some clusters, but it's not something that DOH shares on a regular basis. Age distribution is something that's also shared for case counts, I think, but not for other categories. So there's a wide variation in what gets shared in what ways. So I think that is something that the Resolve to Save Lives report, which I wrote about in my last Sunday's column, pointed out. There's not a lot of disaggregation, something we talked about earlier with the terminology slides. I think to a certain extent, there has to be more of that breakdown. And like contact tracing, you brought up contact tracing. I think a lot of our readers actually sent in questions about to what extent does the state do contact tracing? We don't know. Do you guys know?
Yeah, there aren't regularly reported metrics on that. So
exactly.
And that was on the leading to lagging slide that I talked through earlier, is that's just something that really helps us understand what might lie ahead as to what extent our capacities are keeping up with demand for that tracing and testing. I think that's a very important metric that I would love to see publicly reported.
Right.
Definitely, and to add to that, for how we could, for the public to be aware, what we're working on is, our goal is to utilize as many leading indicators as possible, because we want to provide policymakers with as much lead time to make decisions that are not reactive but are proactive. And with regards to contact tracing, we are working as a team to develop to incorporate contact tracing in terms of, if we have X number of contact tracers who can contact trace on average Y number of cases, and based on our 14-day projections, will we reach capacity due to contact tracing? And if that's the case, then deferring that decision to the policymakers in terms of what would they do, telling them, hey, this is one metric, which is a very important metric. Now that, leave it up to you to do what you will with this information. But at least we're not waiting until we see the hospital cases increase, which at that point is much too late. We're still able to prevent some of the impact utilizing leading indicators such as contact tracing capacity.
Mm-hmm.
And I'll also say, Thomas mentioned the hospitalizations and things like that. That's another area that we would love to see more transparency on. Is we do see new hospitalizations reported daily, but we don't know what that translates into in terms of hospital capacity. We don't know how long people are in the hospital, whether they're going to ICU, et cetera, on ventilators. And that was an early conversation, is that when will we hit peak hospitalization? It's still relevant today. We are now trying to manage a balance between economic recovery and public health. And one of the ways that we would understand how we're doing in that regard, that helps us put into context the number of new cases we're seeing every day, is to what extent that's translating into strain on our hospitals and compromised health for those that are getting sick. And so better accounting of that, it is accounted for. It's just not publicly shared. But I think the public would benefit from seeing what's happening in our hospitals at an aggregate level, at a state level at least, or county level, would really be important to get the full sense of how we're doing in that balance of economy and public health.
On that note, I do want to ask you guys, what sort of hospitalization figures are available publicly?
Publicly, the only one I'm aware of is the new hospitalization. So we there's a tally that's reported. So how many hospitalizations by county, and we could do our math to say, well, how many is that minus yesterday, and that's new. But otherwise, we don't get anything beyond that. So yeah, Thomas, I may be missing something, but that's all I'm familiar with.
Yeah, I would say the best source right now for publicly available COVID data is from DOH, and I do follow the Lieutenant Governor, and he does do his daily Instagram posts where he updates the number of ICU, I believe, capacity or utilization, as well as I believe hospital utilization of ventilators. But once again, it's just a cross-sectional or snapshot in time. It's great, the information he's putting out, but if you're following him, then you would have to track it on a daily basis. And I apologize, it's been a few days since I've checked DOH's website.
Our health reporter, Lenny Gill, just pointed out that the Department of Health just started to give an active hospitalized count, but only in an emailed press release to the media. I would just like to point out that Resolve to Save Lives, this is an organization Nick and I keep pointing to. It's an organization that was founded by the former CDC director, Tom Frieden. It's a public health organization. They just produced a report evaluating all the data dashboards, COVID data dashboards of all the states, Washington, DC, and Puerto Rico, and found that basically everybody's doing a terrible job. But not necessarily because everybody's bad, but because there's no federal consensus on what indicators should be the set of indicators everybody should consider for COVID-19. And that was it. So I just wanted you guys to know for reference, and I will post a link in the chat.
Yeah, systemically, that would make a big difference if there was federal level leadership on this very topic, where each state had clear guidelines on data accounting and reporting that would then help us not only have access to good data locally, but also be able to contextualize that relative to other states that would be reporting in the same way.
And before we get to the chat questions, I wanted to ask one more question that came through the forums, and I will just read it word for word. Is there sufficient cooperation, communication, collaboration between sources of COVID-related data, hospitals, DOH care facilities, military, and processors of such data, modelers, data scientists, policymakers, to ensure an optimum response to the pandemic?
It's a very nice question.
What do you
I would say it's certainly not optimal. There are challenges, and for those of us outside of the agencies to get access to the data we need. And I say that as a participant and member of the HIPAM group that Thomas described earlier, that there are data requests going out. And more recently, there has been an openness to starting to explore how a pipeline of data from DOH could support a model group such as this. So we're making progress, but it's been slow. I think that's fair to say.
Definitely, I would agree with Nick. Obviously, my position for the past 3.5 months with HIMA granted me access to information that the public didn't have, but once again, I was very sure to keep that confidential with regards to my position due to my activation of military orders. But now, as more of a civilian aspect, I would say that there are some very key data points that are still not yet publicly available. But I would say it's not due to lack of trying from multiple agencies. It's just remembering that while we are now 4 to 5 months out of the initial COVID response, remembering that a lot of these agencies are very large, and it does take a while to get them up and running, to coordinate and communicate effectively. But once again, that's not excusing them, because this is an emergency in a sense where it's very critical to get this data out, but we need to shift from an emergency response to a more sustaining response, because we do know that this is going to be with us for quite some time. So we need to provide either daily or weekly data uploads or downloads for the public and for researchers to have access to better assist not just policymakers, but Department of Health, because really how I see it is we really are one Ohana, one team when it comes to Hawaii, and really addressing all these issues together. And to me, it's all hands on deck from not just the university aspect, but once again, from HIPAM, working with our community partners. We have representatives from Queens, HPH, and other community entities regarding data and health to really tackle this together, and not trying to create any silos, but really to break them down and to get at this together, to get all these multifaceted organizations together to make sure we're capturing all the essential aspects of this for Hawaii.
All right. I did forward this very question to Dr. Sarah Park, the state epidemiologist, and I received the following written response, unquote, all government and healthcare partners have been collaborating throughout this pandemic response, end quote. All right, and we will now move on to the questions that came in through chat. I was keeping an eye on the questions that have been coming through. Some of them, I'm sorry to say, we can't answer. Our panelists can't answer because, you know, they are not representative of DOH. Representatives of DOH, and you know, they appear to be questions that those people would have to answer. But so please forgive us for not getting to, and also there are so many of them, so please forgive us if we don't get to all of your questions, but we'll try to get to as many of them as possible.
Don't stop asking those questions. It's just not necessarily questions we would be able to address here. Very important questions.
Yeah, I mean, and thank you everyone for asking these wonderful questions. We just may not be able to answer all of them or get to all of them. All right. Okay. Thomas, here's a question for you. How often do you check the reasonableness of the assumptions in the various models?
That's a great question. For everybody out there, regardless if you're a trained epidemiologist, which you know assumptions are the key to everything that we do, or to a budding or very interested epidemiologist, my team, at least when I was doing this on a full-time basis, every day, even on the weekends, I would always check my assumptions every day based on new data, not just for Hawaii, but what we're seeing globally. I would really look at the major findings from peer-reviewed journals in terms of the virology, collaborate with our subject matter experts when it comes to our infectious disease docs, because once again, I am not a clinician, but I asked our expertise whether or not the change, you know, how the spread of the virus has shifted. I would say around, please forgive me if I'm getting the day wrong, but I believe around May, we learned that the virus had mutated in the United States to become more infectious, thankfully not increasing in its lethality, but definitely increasing in its infectiousness. And we saw that and we saw a result of that in Texas, Florida, et cetera. So what we adjusted our models to account for that, as the mainland increased in the number of cases, especially in the states that we have historically seen a lot of our travelers come, we then adjusted our scenarios and some of our assumptions for that. So long answer to a very good question is yes, we check it every day, not just from a purely epidemiological standpoint, but from a virological and a laboratory testing capacity as well, because we know that the more time we have, the better our screening and testing technology is going to be, and also our capacity. And therefore, if we have weeks where our testing capacity is lagging, then we take that into account. And once we catch up with the supply chain, then we will make those adjustments as well. So we definitely pay attention really on a daily basis.
Can I chime in real quick? Just an observation, and definitely the benefit of all the learning that I've had by being able to work with Thomas is also misunderstanding we encounter a lot is the difference between models and scenarios. And scenarios are informed by models, but and it's actually probably the more appropriate distinction is the difference between a forecast and a scenario. But you know, what we should only be comfortable with forecasts that take us out 2 weeks, maybe a month, something like that. And even Thomas at a month is starting to shake his head a little bit. So you know, just one thing for the audience is that when we see things that are taking us out months, those are scenarios. Those are and the assumptions upon assumptions that go into scenarios are even greater. A forecast has assumptions enough built in and needs to evolve as we better understand COVID. But to then scenario out months in advance where so many things can change in unpredictable ways, they're useful in that it allows us to imagine in a rigorous way what might happen under different conditions. That's not the same as a forecast. It's not what will happen. It's like Thomas's travel scenario. That's not what will happen under different kinds of things, but allows us just to kind of understand today what might happen later based on our best understanding of the virus transmission and the assumptions we have about how many people are going to start traveling again, things like that. So I think that's also really important, is different assumptions and different use cases for forecasts in the shorter term and scenarios in the intermediate and longer term.
Exactly. And just one final note on that, we all saw how quickly the forecast for hurricane, right, for that hurricane shifted hour by hour, right? And really COVID forecasting is no different. An easy, a hypothetical example for everybody to understand is, once, let's just say theoretically tomorrow, there's a very effective treatment that is cheap, that significantly reduces the mortality and morbidity of COVID, then that's drastically going to impact not only our scenarioing, but also our forecasting. Maybe not the forecasting the next week, but definitely our forecasting as we move forward in the next month. So once again, at any given point in time, there could be a huge advancement in our science. And then once, like the astute commenter said, we would revise our assumptions to make that reflect what we actually understand.
Since you guys gave such long answers, that cut into our time for asking more questions. If you guys have a few more minutes to go over 3 o'clock, we can ask another question.
Sure.
Would that be okay?
Yes, that's fine.
All right. So I am going to combine 2 questions into one. One person asked, why is federal guidance needed, and can Hawaii opt to share data? And the other question was, will there ever be a nationwide standard to data that is reported?
Ooh, I'll take a first step.
Okay, go ahead, Thomas.
So, with regards to will it ever happen, that's unfortunately that's way above my pay grade. That's at the high federal level. Whether or not federal guidance is needed, once again, it depends on federal guidance for what. But I would say, from a public health perspective, federal guidance is always appreciated because it keeps consistency across all the states. And we've seen that different states have had has had differing successes and responses to COVID based on how they've educated their state citizens on what to or what not to do. But having a standardized response, understanding, first of all, that response can change on a dime because we might discover something different. Everybody likes to point to CDC saying don't wear masks in March and February, and then all of a sudden wear masks in May. Once again, there was a reason because of the PPE shortage, but but that did help people kind of be standardized in their approach. So federal guidance is necessary. In terms of data, it would be very helpful because we need to address this at a nationwide level to get all the data on track, so we can communicate within states in terms of all of our trends and be consistent with the data and how we report the data. And then theoretically at a federal level, someone's coordinating it and adjusting policy at a federal level based on the consistent statewide data that we're getting from COVID. Nick, if you have anything else to add.
The only thing I would add is that there might be part of the nature of that question was around, the independence of states relative to federal requirements and things like that. And I think it's just really important to consider the balance. We do have a freedom of travel between states. We do have shared resource use. We have shared goals as a country. But I also do, understand that there's concerns around the independence of states and the ability to adapt and react locally. So I think it's finding that balance, and a lot of them are framed as guidelines, but I do think for all states to be able to benefit from the scale that comes from a robust CDC, for example, there would be some things that would just need to be standardized so that we're all talking about the same thing and we're understanding collectively what's happening, in our country.
One more super quick question that I would like for both of you guys to be very brief on, but I just saw it in the chat and I thought, I want to know the answer to this question. Do you think the cumulative case counts are helpful for the press and government officials to report every day, or should the focus be on new and active cases?
I can go first. We, for those who might have seen our COVID-19 landing page and dashboard, we made a pivot, I guess 3-4 weeks ago at this point, from highlighting the cumulative case counts for Hawaii to highlighting first 5-day and now 7-day average of new cases. And the reason we did that is because at some point it seemed more like keeping score than actually reporting something that was useful as something that we all who are concerned could react to. Because cumulative cases now goes all the way back to March. And so, you know, that does tell us overall, okay, it's adding up, right? But and it was relevant very early on because it was, you know, in the first month or even two, it's just, you know, how many people are going to get sick. But now as we kind of navigate the new normal with the kind of the ebbing and flowing of case transmission, it really is for us, the priority is the 7-day average of new cases, because that gives us a sense of, you know, what's happening now.
I agree. Well, you know, this is a perfect example of not all data is created equal. While cumulative data is good for historical purposes, for policy and modeling perspective, it's really not the ideal one. Really, active cases and daily new cases, but not just a daily, but a 7-day average or a 5-day average like Nick addressed, really helps us adjust for any single day spike. But really from an FB and a modeling perspective, the active cases, you know, once again, that's very nuanced. It's not just how, you know, the difference between cumulative versus recovered, but of those active cases, how many have been, where are they in their 14 days in terms of quarantine, isolation, because that really helps us in terms of looking at immediate future spread of COVID. If majority of them are in isolation, then I'm not too worried. If the majority of the active cases are recently discovered, then I'm much more concerned. So once again, there's nuances, but active cases are definitely one of those that are useful. But with the illustration that I gave, there's still more nuances that we need to get that unfortunately are not available to the public.
All right. Well, thank you guys so much for joining us today. I hope, sorry everybody, we didn't get to all of your questions, but Alana is gonna give you instructions on how to send questions our way so that we can try to answer more of them in the near future. Thank you so much. And thank you to the panelists. I will turn my mic over to Alana.
Thank you, Yoohyun. I wanted to introduce Ben Nishimoto, our Vice President and Director of Philanthropy at Honolulu Civil Beat, so he can say a few words before we wrap this up.
Thanks, Lana. Just a few minutes. First, you know, thanks to Yoohyun, Nick, and Thomas for lending your expertise to this event. We have around 200 on the call, so there's obviously a ton of interest in this topic, and we'll be holding more of these data conversations over the next several weeks. As Alana mentioned earlier, you know, Civil Beat, we're a nonprofit newsroom. In addition to the in-depth public affairs reporting that we do, we are also very committed to holding events such as these. Normally they're in person. At this point, obviously we're transitioning to all online events. And we're really looking to build community through sharing information that we feel is vital to create an informed society here on our islands. You know, 2020 marks Civil Beat's 10-year anniversary, and we're using the opportunity to do two things. First, to thank you all who have supported us since our inception back in 2010. We obviously can't do this without you. We have about 4,000 donors giving various amounts. Secondly, we want to use this opportunity to ask new readers to really step up and support our work. You know, every dollar raised goes right back into strengthening our newsroom. That's the cool part about being a nonprofit. And, you know, asking for support is not something we like to do, especially during this time, but it is something that we need to do in order to make sure that our journalism remains free and independent, but also well-funded. So people like reporters like Yoohyun can do the good work of sort of informing us on a daily basis. So for the next month, as part of our 10-year anniversary, in exchange for a $5 monthly donation or a $60 gift, we're giving away a pair of Civil Beat face masks. So at risk of turning this into an infomercial, I just want to show you briefly what this looks like. So you've got the logo there. It's 3 layers and we're offering that as 2 of them for existing donors who make an additional $60 gift, or for new donors who make a new gift. So you can visit civilbeat.org/donate to pledge your support. You can also send a check to our newsroom. The address is on our site and on our donate page. And if you have any questions about Civil Beat or anything on the operations side, you can feel free to reach out to me, bnishimoto@civilbeat.org. But thank you all for coming, and I'll just shoot it over to Lana.
Thank you so much, Ben. I just wanted to wrap this up with a huge mahalo to Yoohyun, Nick, and Thomas. Thank you so much for informing all of us. I learned so much myself in just planning this event with you guys. So thank you so much for doing this, and for our Civil Beat readers. And we had people from all over the world attending this. So everybody who's still with us, you will be getting a copy of this recording. And I will also be sending out the slides that you guys can refer to. If you have any more questions for Civil Beat, just email us at membership@civilbeat.org, or Yoohyun also put her email address in this slide up here. Feel free to email her directly. You can check out Hawaii Data Collaborative, hawaiidata.org, and the HiPAM site, hipam.org. And Yoohyun, did you want to say anything else to wrap it up?
And I put the Google form to ask your data questions through the Hawaii variable form. So you can always send your questions there as well. Thank you so much. Thanks for joining our webinar.
Thank you. Bye, everybody.
Thank you.